Welcome to this special Gastro Girl podcast. This episode was produced in collaboration with the American College of Gastroenterology's Patient Care Committee. Here's your host, Jacqueline Gollin.
Hey, Gastro groupies. Welcome to this episode today. We're so excited. We're going to talk about a really interesting topic, E0E, otherwise known as Eosinophilic Esophagitis. Our amazing guest today, Dr. Milli Gupta, is here to join us, and she's going to tell us all about E0E from a perspective of just being diagnosed. Now, Dr. Gupta is an assistant clinical professor in gastroenterology and hepatology at the University of Calgary. She's also a very active member of the American College of Gastroenterology's Patient Care Committee. Thank you so much today for joining us. Dr. Gupta, welcome to the show today.
Thank you so much for having me, and thank you for doing such great education podcasts for patients. It's sorely needed.
Well, thank you, and the pleasure is all ours. We really appreciate the collaboration with ACG's Patient Care Committee to really bring experts such as yourself to our podcast for patients to really get the best insight from the top experts in the world. So, I'm just going to dive right in and have you explain. So I just got diagnosed with E0E. What is it? What is it, Dr. Gupta? What is E0E?
Yeah, for sure. So if it's okay with you, I'll say E0E to save us both the anxiety of saying the huge word. But as you beautifully said, the word is eosinophilic esophagitis. And so the disorder particularly applies to the esophagus, which is the food pipe, and that connects the back of our throat and mouth to the stomach. And when you use the term eosinophilic, that is particularly referencing a type of white cell that is attacking the esophagus and causing inflammation. And that is called esophagitis. So the term E0E encapsulates or puts together what is actually happening in the esophagus, which is we are having active inflammation, a type of white cell attacking the esophagus. And we don't know why it's doing it, other than to say that we believe it is linked with food allergies. Eosinophils are a type of white cell that we often see when a person is experiencing an allergic reaction. So by having a lot of these type of cells in the esophagus, we are appreciating a type of allergic reaction, a type of allergic inflammation in the esophagus. That causes stickiness, swelling, or inflammation, and changes to the way the food pipe can work. Typically, a food pipe has a lot of flexibility in it. It's like a rubber tube. It can expand and it can shrink back when we're eating. But with this disorder, there is a bit of scar tissue that starts to form, and that scar tissue makes it less possible for the food pipe to stretch. So that is often why patients with this problem will have difficulty swallowing or pain swallowing.
That's a great description of it, Dr. Gupta. And to pick up where you left off, can you explain some of the symptoms? And patients might not be aware. And I know that you told us earlier that adults and children experience different symptoms. So let's break it down for the pediatric population and also for the adult population. What are some of the symptoms that could be experienced before they get a diagnosis?
For sure. So children often will have different experiences than adolescents and adults. So my practice is predominantly the older group. So with children, they may present with difficulty swallowing, but often it'll be pickiness with food. They may have vomiting. They may have abdominal pain. They may also have growth failures or malnourishment because they just don't want to eat. Sometimes they can have rhinoconjunctivitis, which is a very fancy way of saying runny nose and inflammation within the ear, nose, and throat area. So they may not actually see a GI doctor or gastroenterologist first. They may actually be seeing an ear, nose, throat specialist and then get transferred over to a gastroenterologist for assessment. In the adolescent and adult population, most often patients will experience difficulty swallowing. They'll often be told, oh, you're swallowing too fast. Take your time and chew your food, or don't get so distracted when you're eating. Sit down, take your time and eat. These are often the type of feedback patients may get. And when they get that, they kind of go, okay, well, it's just something I'm doing incorrectly. I just have to take my time, or, it's just a one-off, not to worry. But often it is that difficulty swallowing, that sensation of something getting stuck in the chest or a pressure. And often people will take the time to go to the bathroom and vomit it up or force themselves to vomit. Because of all of these behaviors, often adolescents and adults will learn how to adjust for these problems. So they'll adapt, they will make adjustments in their lifestyle for this problem and disorder. So they may choose not to eat in public. It's a very socially anxiety provoking disorder at times. People may choose to just eat soups or liquids. They may actually say, I'm not going to eat. Or when they do eat, it's often they're the last ones at the table because they're having to lubricate and take liquids with each of their bites. So there is a whole context to this problem that can really impact not only their physical health, but also their ability to engage in community and society, where food is such a big part of our lives.
Yeah, it's almost like stressful. Like you never know what's going to happen. So is it certain foods are different? Do patients have different triggers for their reactions, what they're experiencing, maybe difficulty swallowing?
So that's a great question, and we will likely have to break it up into chunks.
Yeah.
So I'll try to focus a bit on the symptom side, and then the diet actually may play a role in treatment. So then we will talk a bit about that. So when it comes to the type of foods patients often will struggle with, it'll be meats, dry foods like breads, cinnamon buns, like sticky foods, because essentially, as I was saying to you earlier, when somebody has this disease, there is a lot of inflammation in the esophagus, and that inflammation can trigger a bit of stickiness to the lining of the esophagus. So that stickiness can often make it hard for dry foods like breads to go down.
Yeah.
As well, the scarring can actually make it harder for the food pipe to move things down and squeeze. So then foods can get stuck and lodged. Now, that is why eosinophilic esophagitis can be implicated or can be a cause of food impactions where food gets lodged. And that is actually a medical emergency. And we really recommend patients come into their local emergency departments to be seen.
That's really interesting. I actually had a friend who was experiencing that for many years, and she never got the right diagnosis. And then it took years for her to get a diagnosis of EOE. But every time she would eat certain foods, especially like a chicken kebab or something, it would get stuck in her throat. And she had to go to the emergency room a few times.
So yeah, like that is not normal. So, and I wanted to, if I can ask patients to take one thing away, it's to know that it's not normal to have food stick. It's not normal to have food lodge like that and having to, vomit or upchuck. It's not normal. Please go see a gastroenterologist or a doctor about this. In the past 5 to 10 years, a lot of non-gastroenterologist doctors are becoming aware and well versed in the knowledge of this condition, so they can step in and help you and guide you to the right resources. And with the food impaction, often what patients will need is a way for a gastroenterologist to put a camera into their mouth, into their food pipe, and take that food out. And the reason it's important we do something about food getting stuck like that, because it can cause something called a perforation. Perforation is a fancy way of saying a tear in the lining of the esophagus. And that's something we don't want you to have. It's painful. It's got a lot of complications. We often have to admit patients, give them antibiotics, and intravenous nutrition. So you can't eat or drink for a few days, if not weeks.
Yeah. So definitely the takeaway message here is if you're experiencing any of the symptoms that Dr. Gupta just explained, to get to your doctor, or if it's impacted your emergency room right away.
Yeah, and as patients, your families are also involved in seeing you suffer and your social contact. So if you know somebody that is struggling like that, it may be worth guiding them to go see somebody about it.
Oh, great point. That's such an important point. Because, like you said, eating and eating together is very social, a social experience, and we don't want anyone suffering in silence. So before we get into the diagnosis, Dr. Gupta, is there a particular set of risk factors? Are there certain patients that are people that are more at risk for EOE than others?
Yeah, so this is where it's interesting, and we don't fully understand why, but we do know that men are 3 to 4 times more likely than women to have this condition. And it is usually all ages that can be impacted, but it's predominantly adolescents and adults that have this condition. Thankfully, it is not linked with cancer, but it is a lifetime problem once you get diagnosed. So it's really important that we see these patients. Ethnicity-wise, surprisingly, it appears to be a disease that is more common in the white population rather than Asian Americans, African Americans, or even Hispanics. So it is very important that we recognize that while there is this mismatch in ethnicity, it is still important that if you have symptoms that you come in and be seen. Interestingly, there seems to be an environmental trigger for this condition because, as you were suggesting earlier, up until 20 years ago, we didn't really know much about this problem. Even in the 80s, 90s, people were taking biopsies, they were being evaluated by specialists, but they wouldn't see this white cell presence. But it's since the 90s that we've seen a huge rise. And so we do know there's an environmental trigger. As I mentioned, we think it's a food trigger, but we don't know more than that. We also know that northern regions in the world, dry climates, appear to be more likely to have this condition. And the summer, springtime is when people are more likely to have these presentations or flares of the disease. So they may come to attention at that time.
This is interesting. So I want to ask a question because of the focus in the last couple of years, especially the last 2 years, of diversity and inclusion and health equity. You mentioned that the more prevalence in the white population. Is it because, and maybe this is just, there may not be enough research around this topic, but is it going out on a limb to say maybe there's not enough data in the African American population, and enough recognition and awareness in Hispanic and other ethnicities of this disease, and that's why they're not going to get help and it's not known?
Definitely. And I also think as globally, we're all improving our levels of wealth and health. And so you're right. One of the things that is linked with this disorder is that cleaner environments appear to have a higher association with this disorder. So this idea that is linked with many other disorders like asthma, inflammatory bowel disease, where if you don't have as many allergens in the environment to trigger your immune system's growth as you're growing from childhood to adulthood, that may be a risk factor for why you are acquiring these allergic conditions later in life. So I 100% agree. Part of it is that we perhaps have not studied the populations adequately in the United States, for example. The other is the environment as well. Perhaps that is a contributor to why we're seeing so much more of it in Western countries than Asian and African countries.
Interesting. Well, hopefully we can help get the word out with this podcast and other informational resources that the college is developing as well. So thanks for that insight. So let's talk a little bit about diagnosis, Dr. Gupta. This is probably where your expertise really shines. What does a patient have to go through and their doctor in really finding the right diagnosis of EOE?
So there's two things that ends up happening. If a person were to present in an emergency setting where they've had something get lodged, at that time, the doctor is going to do a camera test called an endoscopy or a gastroscopy. So the camera is often a noodle about the diameter of my finger, and it'll go into the mouth, the back of the throat, and the doctor will use fancy tools to remove that item of food from the esophagus. And often at that time, they have the ability to visualize and see what the esophagus looks like. And often there are features of this condition that are visible. So the doctor may choose to take biopsies, or they may say at that time, the appearance is so classic, I'm going to go ahead and put you on treatment. If a person is having some grumbling symptoms of difficulty swallowing, pain swallowing, they go to see their doctor, and the doctor then does the camera test. They will then definitely be planning to take biopsies at that time, which are small tissues, very microscopic tissues of the top layer of the esophagus, and send it to a pathologist who is a specialist in evaluating the tissue. Now, this doesn't hurt. Often these tests are done with sedation, either with anesthesiology in the room or not, but the safety and the comfort of the patient comes first when these tests are done.
That's great. We did some earlier podcasts where we talked to patients about their journey in getting an EOE diagnosis, for instance. And oftentimes it took them a long time because they were initially, presenting with similar symptoms like you would feel with heartburn or acid reflux. So they were put on a PPI, right? And then the PPI is not working, or it's doing other things to the microbiome and the whole digestive system, and they're going down the wrong path. So can you provide a little insight on that? Say a patient, they maybe have some of these symptoms right now, they're listening, and their doctor maybe gave them an acid reflux medication, and they're still not feeling good. What would be your guidance for them?
So great question. And thank you for bringing this up. So reflux is an imitator of this condition because eosinophils, as I said, is a type of white cell. And so one of the imitators of this disorder is reflux. And so it's really important when the doctor is doing the camera test that they take biopsies from various areas of the esophagus to differentiate or separate out reflux patients from EOE patients. As you can imagine, there are some people who have both, and that's where it gets confusing. But having said that, like you said, EOE can be treated with PPIs, which is the reflux medication you're referencing. And the way this medication works in EOE is something we don't fully understand. It is an anti-inflammation medication in some aspects, and that is what we are taking advantage of when we give it to patients with EOE. So please do know as a patient, if you're hearing this, that when your doctor is putting you on a PPI or a reflux medication, they're not doing it because they think you have reflux. They're doing it because they want to see if you respond to the treatment, because it is a good treatment in EOE as well as reflux. In scenarios or instances where it is hard to differentiate between the two, it's really nice that we have a simple treatment like this that kind of treats both things and possibly helps. Now, you were asking what happens if this treatment doesn't work?
Or they get other symptoms, like they have other digestive symptoms as a result of the PPI.
Yes.
There's all sorts of things that could happen.
And yeah, for sure. Yeah. So if PPIs give you side effects or you're not feeling better, there is sadly two aspects to that as well. So one aspect is that the medication may not be working for you. The other is that it could be working for you. And unfortunately, at this time, when it comes to this disorder, we know there is a disconnect between how patients feel and what is going on the inside of the esophagus. So patients may not feel well being on the treatment, but if we can show them with objective measures that their disease is improving, we have to then decide with the patient, what is it that we should do moving forward? So the objective measures are the tissue samples taken from the esophagus. There is a lot of literature being published that says people can still have symptoms even if their disease is in remission, which means that it's been taken care of and it's in healing. And
that's interesting.
It is an extremely confusing, scenario to be in, because as a patient, you're struggling, you're looking for a treatment, yet the doctor may be saying to you that the treatment is working. And if that is happening, there are further options we can pursue. There are 3 Ds when it comes to the treatment of EOE. There is the drugs that you've mentioned, and there's a few more we can talk about. There's diet, and then there's dilation. And dilation may be the step that you may need if you are having a disconnect between how you're feeling and what is happening with the inflammation inside your food pipe.
Okay, this is great because it's a great segue to the treatment option. So let's go through those 3 Ds that you just described. What would be first, and what are the options that patients would go through? And I know diet's a huge, complicated one, but it's a really important one, and it's probably one of the most challenging one for patients because they really have to be on top of what they're eating and understanding, but it can be really worthwhile in the long run. So let's just back it up and go through if I was just diagnosed, Dr. Gupta, what would you tell me my treatment options are?
For sure. So the 3 Ds again are diet, drugs, and dilation. So drugs, as you've mentioned, is PPIs or proton pump inhibitors. The second is topical steroids. And the third are experimental clinical trials that may be available in a center close to you. So PPIs, we've already talked about, they are great in that they give us both reflux control and possibly EOE control. They may not. So if you have ongoing inflammation that the doctor confirms is present, even though you're on PPIs, then the doctor may suggest you to take medications like topical steroids or to do diet. Topical steroids are currently not FDA approved, but they are approved in Europe and Canada. So because of that approval in other places, they are bringing those type of medications to the United States and doing clinical trials in the hopes that the FDA will go ahead and approve them in the next 1 to 2 years. The nice thing about these steroids is that we have learned a lot from the asthma and eczema literature. So topical steroids are like putting a steroid cream on a bug bite. They help to calm the inflammation down, and they only act on the area you've applied. So they do not get absorbed into the rest of the body. They don't have the same side effects that prednisone or methylprednisone or any solumedrol, any of these terms you've heard. They're big guns that can be used to treat EOE, but they are so rarely used because they just have far too many side effects, and the amount of side effects are not worth exposing you to. We can use the topical options.
Oh, great.
Clinical trials are something that are available in expert EOE centers, and there are so many in the United States. You just have to Google, and you will likely find one close to you that will likely enroll you based on how you've done with the treatments.
And can you just speak a little bit about the clinical trials for patients? I think there's this maybe stigma, a clinical trial. I don't want to be a lab rat, but I think there are some really huge benefits, especially when a lot of these treatments have been approved in other countries. And the FDA process is a much longer process. Doesn't make it good or bad, but can you explain to a patient, like, I'd rather try one of these trials. Like, what should I know about the clinical trials?
Yeah, for sure. So with the clinical trials, they're using monoclonal antibodies right now, which is very similar to what we use in inflammatory bowel disease. So it's an antibody that has been created in the lab. And after researchers have studied EOE and sorted out that there are 1 or 2 specific immune markers that are good to target and safe to target, the researchers will go to the lab and create an antibody to give to patients and see if it'll help with their disease. Now, before the drug will make it to the scenario that you are now looking at to enroll at an expert center, the drug has been rigorously studied in animal models. It has been given to healthy volunteers to just make sure there isn't any adverse events, any side effects that might be troublesome and problematic down the road. A lot of times with these clinical trials, what you're really getting access to is the drug earlier than the majority of the population. The studies are very rigorous. The FDA is a very excellent and thorough organization. So it completely makes sure that the patients are monitored, that they are followed, and that if they have any questions or concerns, they have the opportunity to not only speak to their doctor, to their nurses, but also to the FDA organization as well.
That's great insight. And I think for patients, right, the best way to know if you qualify is to talk to your physician, see if it's something that would be appropriate for you. And then I'm sure there's lots of questions before you even can enroll in the trial. So they do a good job of really kind of making sure that you're the right candidate for that.
Correct. They're looking for your success. They're not looking to further a drug that may not be beneficial to you.
But that's a really good point. So thank you for providing insight on that.
Mm-hmm.
So what D are we on now? Diet.
Yes. So diet is the one that everybody is most excited about.
Yes.
So diet is really important in the pediatric world because they like to avoid giving medications. In the adult side, it is a lot harder for young adults to adjust and make dietary modifications, especially, again, as we said, it's a very social and age group, and they are getting to make friends, meet people, a lot of peer pressure. So it can often be hard for this group to do diet, but if they are willing, there are some really good evidence and research behind diet. So there are various ways in which you can pursue diet. Often people think allergy testing is a way to diagnose and figure out your food group. Unfortunately, allergists and gastroenterologists both agree that the nature of the disease is such that the current type of IgE testing we have is inadequate to detect which food group is your trigger. So
I want to stop there because there's all these advertisements on TV lately about these, hey, I took this test and now I know what foods bother me. So this is what you're talking about. Those aren't going to necessarily be accurate for an EOE patient.
correct. So they are accurate for other problems. Like that's why we recommend seeing an allergist, because often eosinophilic esophagitis patients will have family histories of this condition, or there may be asthma, eczema, allergic conditions. So that is a risk factor that I forgot to mention, that having asthma, eczema, or other allergic conditions increases your chances of this eosinophilic esophagitis problem. So if you have an allergist already engaged and involved in your care to help manage your other conditions, it's really important to keep going with that, because we do not want that to be interrupted or changed in any way. It actually helps control your eosinophilic esophagitis down the road too.
That's good.
So with the eosinophilic esophagitis diets, they have done various types of diets. So I've already mentioned allergy directed, tested, which don't really work. Then there is something called elemental diet, which is so hard. It's basically amino acid based foods that are in containers, in cans. Adults never do it because it is just so unpalatable. And children, it's only used in severe cases, but there is very good evidence for it. So it does work when you do it, but we don't expose people to it because it's just really not flat. It's not a long-term solution. And we're looking for long-term solutions with our patients. So the most common food groups that we will recommend avoidance of are 6 big categories. And based in conversation with the patient and what they wish to do, some will choose to avoid all 6 food groups at once. Some will want to do 1 or 2 food groups at a time. The biggest thing to remember is that we're not asking you to eliminate all of the 6 food groups for the rest of your life. That is not the point. The point of the diet is to identify which is your food trigger, so you are then more educated, empowered, and aware in knowing what food group you should avoid and which one is your problem food group.
Yeah, and I know this sounds so daunting, but I want to suggest something. We're really fortunate to have a great collaboration, Gastro and ACG, for this GIOnDEMAND. And GIOnDEMAND has created an on-demand course program, and one of the modules include E0E. So we have 2 courses right now, and they're both led by E0E expert dietitians who explain this elimination diet, the 4, the 6 food elimination diet, or 2 food. She walks you through all of them to kind of see which one is best for you. And then there's also a nominal, that's free, the intro, but then there's a nominal charge one. It's almost like working one-on-one with a dietitian who will give you all the handouts you need, or if you're a caregiver for the person that needs to do this elimination diet. I say this because I want to put a spotlight on these courses, but the importance of working with a registered dietitian with GI expertise. So whether you do one-on-one, oftentimes many of them are virtual, but you have to make sure you're working with a GI expert registered dietitian, not just a nutritionist or a health coach that says they have EOE experience, because this is a very serious disease. And we want to make sure that you're getting properly nourished when you're eliminating things. So we have these courses on GIOnDEMAND, and also RDs. Please look for RDs that are expert in GI. So
thank you so much. And that is so key, because we don't expect patients to do this on their own. It is overwhelming. We definitely want you to do it with a dietitian, because you need the support. You need the understanding of how to read the food labels and the boxes, and how to clear your pantry if you're going to do this. And as Jacqueline said, you may start with a 2 food group elimination, or 4 food group elimination, or a 6. And the food groups I should mention, they're cow's milk, wheat, eggs, soya, nuts, and seafood. So it's a comprehensive diet. And the biggest food groups that people often struggle with are the ones that are implicated in this disease the most. It's dairy and wheat. Dairy alone has up to 45% chance of being positive in our patient population.
Wow.
So just even dairy on its own. Now, there is publications and literature coming through in the next 6 months to a year that'll guide the gastroenterologists on what is the evidence when you eliminate only dairy. But we do know that if you were to do dairy and wheat, you do raise the chances of finding your food trigger in 50% of the people with this disorder. So it's huge.
Yeah. And then once you find the food trigger, it's not the end of the world. You would avoid those foods. And this is where a dietitian can really help you understand what to substitute. So you're still getting proper nourishment without, depending on those foods that are your triggers. So again, a push for RD involvement because they're so critical to this process.
Definitely. And they're so wonderful. They really take, at least the ones I've worked with, they're so caring. They're so thorough. And the biggest thing for the patient to remember is that it's not only your symptoms that are going to guide whether the treatment or the diet you've chosen is a success. It's the doctor doing a camera test after you've done the diet and had the diet in place for 8 weeks. You need a camera test again with samples, because that is how you and the doctor will know whether the adjustment and change you've made in your lifestyle has helped you.
And one of the questions that always comes up is does insurance pay for this? And, it depends, right? It depends on what your plan.
And most often, the other thing to remember is that if you are going to a gastroenterologist and they're an expert center, they will often have a lot of these resources available to you. And so insurance companies are usually pretty open to that as well.
So I have one more question before we get into some of the, you're not alone. You're not alone with this. There's some great support groups, but what does remission look like for EOE patients? Like, what does that look like for them? Or what does that mean for them? We hear that term for other things like IBD or, other disease states, but what does it look like for EOE?
So great question. Remission it may be twofold. One is the patient feels really good, and the other is the disease on the inside has been healed. So we really want to make both sync together so that in the future, when the patient continues to feel well, it's because there is no longer any inflammation in the inside of the esophagus, and that there is no more scarring and swelling and the stickiness or the disease active in the esophagus. So to maintain the health of the esophagus is to maintain your health in the long run. We definitely know that if you feel okay, but there is still ongoing inflammation in the esophagus, that it's really 10 to 15 years before which you will end up with a complication like food getting stuck. So 10 to 15 years sounds like way down the road, but when you're 20, it's coming soon before you know it.
Yeah. No, that's great. No, we did, like I said, we interviewed some really great patients about their journeys. And one was an infant, and he and his mom, we interviewed them, and the mom was more stressed out than the son was. He was like, he had it from such an early age that it was just natural for him to manage his EOE. So it was really uplifting and positive. So if you have time, listeners, check it out on the Gastro Girl podcast. It's a mother and son, Jeremy, with EOE. That we did last year. So.
And I wanted to, before I forget, because there were 3 Ds and we only did 2.
Oh, that's right. The other one, dilation. I think I wanted to avoid that one. No, just kidding.
So dilation is important because you may get healing and, like you said, remission of the disease, but the patient may still struggle with symptoms. So that's where dilation comes in. That essentially means breaking up the scar tissue in the esophagus so that the food pipe or the esophagus has the opportunity to function again. So if you break up that scar tissue, the food pipe kind of has that flexibility back in itself. And there are very minimal complications with it. I think people are scared by the idea that somebody's going to stretch their food pipe, but the amount of relief patients get with the ability of swallowing can be profound. So it's worth definitely looking at if the doctor and you have reached a point where inflammation's been taken care of, you're doing everything you can, and you're still struggling.
Yeah, the scar tissue builds up so much that it's almost like, an old pipe that needs some drain out kind of thing.
Exactly.
It sounds so crass to say, but it's like you just want that cleaned out so you can get the nice flow of food again.
Exactly. And, then I've had so many patients say over time that they even forget they have this disease because they have been able to achieve that healing, and they're able to eat and drink everything they used to. So now they even forget that they had at one time ever had to make these adjustments. So it's very uplifting to know that that can occur.
Yeah, I didn't even know about that. They did dilation for EOE patients. That's really, I mean, it sounds scary a little bit, but I see the huge benefit for patients that have so much scarring inside their esophagus. So that's great news. And again, I think the important thing you mentioned before is the support and not feeling alone. And I know you're very passionate about the patient advocacy side and the support groups. So could you just give us suggestions for support groups that you recommend to your patients?
Definitely. So in the United States, there are two very, very good organizations. One is called CURED, CURED, and it stands for the Campaign for Urging Research in Eosinophilic Disorders. And it not only looks at EOE, but at another orphan condition called eosinophilic gastrointestinal disorders. So where inflammation up from the eosinophil can attack the rest of the body or the gut. And then the other organization that puts out a lot of excellent information and that we as doctors rely on to share with our patients is the American Partnership for Eosinophilic Disorders. So it's APFED. And just know that there are a lot of researchers in the United States and Europe and Canada working together to better understand this disease, better find treatments and ways of diagnosing and caring for these patients. So if you do stumble across any of these resources, please do share them around. It really helps to garner more information for this condition and research dollars.
Any other tips or insights that you have for providers or for patients involving EOE? Any last words?
I think you said it all earlier. I'm just going to reiterate it. If you've got swallowing problems, please go see a gastroenterologist or at least your primary provider, because it isn't always normal to have difficulty swallowing. It's really important to get taken care of. And it's also, as a caregiver, it's really important to know that this disease can have a lot more impacts than originally thought. So.
Well, thank you, Dr. Gupta. The time goes by so fast. This is been such a great time spent with you, really learning about EOE, and I hope patients find this very helpful for their new journey if they've just been diagnosed or they're taking care of someone who has. Again, thank you so much, and thank you to the ACG Patient Care Committee for recommending you to speak with us today.
Thank you so much for having me.
Thank you.
Thank you for listening to the Gastro Girl podcast. For more information and resources, please visit gastrogirl.com. Do you have a question for Gastro Girl? Please email podcast@gastrogirl.com. The information, opinions, and recommendations presented in the Gastro Girl podcast are not a substitute for medical advice from your healthcare professional. Please consult a licensed clinician in your state regarding all matters related to your health.